Good evening, ladies and gentlemen. If everyone would be kind enough to grab their munchies and grab a seat, we were going to get started. I'm Dave Sargent, a member of the Miracle Living Committee. Tonight we have three excellent speakers for you. And before I introduce the first one, the modus operandi, if you will, is that we will have our three speakers, then there will be a break when members of the committee will circulate among you with pencil and paper, and you will be kind enough to write down your questions. People are stealing my keyboard. This is Mitch, who without him we wouldn't do anything. Thank you. Members of the committee will collect the questions, bring them up here, and the panel will then address them. Okay, let's get started. Our first speaker this evening is Dr. Panteha Rezaeian. She is a family medicine doctor, board certified in family medicine, and she received her medical degree from Torrance School of Medicine. After relocating to the US to join her family, Dr. Rezaeian completed a family medicine residency program at Loma Linda University and a cardiovascular computed tomography fellowship, say that quickly 3 times, at LA County Harbor UCLA Medical Center. She then spent an additional year in a fellowship for women's heart disease and health at Cedars-Sinai. Dr. Rezaeian actively participates in cardiovascular research and has presented and published numerous articles about cardiovascular disease. In 2020, she was recognized as a member of the Women in Preventive Cardiology Working Group at the American Society for Preventive Cardiology for excellence, innovation, and leadership in preventive cardiology. She's a mentor at American Heart Association's STEM Goes Red program and a diplomat of the American Board of Clinical Lipidology. Lipidology, I had that right, okay. Well, without further ado, Dr. Rezaeian.
Good evening, everybody. Can you hear me well? Okay. So thank you so much for a very nice introduction. So we are here to discuss about one of the most important and serious health issue in United States and actually in the world. So first, I will start with one of the picture of the James Webb, one of the nice picture from the universe, and I will tell you why I'm starting with that. So I do not have any relationship or any connection with any of the pharmaceutical company or medical industry related to this presentation. We are going to start with the definition. What is the meaning of hyperlipidemia or high cholesterol? So what does it mean? So it means that there is the condition that the fat in your blood is higher than it's normal, higher than you need to. And the higher than can just keep you healthy. So that's a definition of hyperlipidemia. And then one thing is that I want to emphasize on that, many of us going and talking about I have a high cholesterol. High cholesterol technically is one type of hyperlipidemia because cholesterol is one of the type of the fat in the blood. And then I'm going to discuss about the different type and then the exact definition and then absolute correct medical terminology about that. So which type of cholesterol we have, which type of the fat we have. So we have the high cholesterol, which could be elevated bad cholesterol, and they call it LDL. And that's referred to LDL, we name it as a bad cholesterol. Why? Because it can blockage the vessels. The second bad fat in the blood is triglyceride. The triglyceride also is the fat in the blood, but is the form that usually can stored in the body. But the origin of those LDL, bad cholesterol, and triglyceride is different. Triglyceride is usually coming from carbohydrate, starch, and sugar. So for example, if sometimes patient coming to my office said, Dr. Rezaeian, I'm doing really good on my diet and I'm really cutting down all those bread and rice and potato, why my LDL is still elevated? And I said, okay, how much of the red meat do you eat? How much of the saturated fat? How much of the, the animal fat or dairy product or eggs or, those animal fat you are eating? And he said, well, I'm technically eating the steak every day, sometimes twice a day. And I said, okay, so that makes sense that your LDL is elevated because LDL comes from animal fat, but triglyceride coming from carbohydrate and sugar. The other things is good cholesterol, we call it HDL. And HDL, just remember, H is similar to, just remind you of healthy. So HDL is the good cholesterol. And sometimes we have a low good cholesterol that also could be an issue in disease in the people. So what is the cause of high fat or hyperlipidemia? What can cause that? It could be either genetics, could be the lifestyle. I told you right now, many people trying to do keto diet, right? That usually increase the bad cholesterol, LDL. Also, the people that have a sedentary life, and unfortunately nowadays, most of us have a sedentary life, also that can cause the elevated triglyceride or bad cholesterol or even decrease the good cholesterol. And sometimes some medical condition like diabetes, the thyroid, especially hypothyroidism, kidney disease, some cancer or some treatment for some disease that they need to be on medication bringing down the immune system can cause high cholesterol or high triglyceride. Okay, so if somebody has hyperlipidemia, so if somebody has either elevated bad cholesterol, triglyceride, or low good cholesterol, which type of disease they can get? So the most important and one of the, very unfortunately serious condition is the coronary artery disease. Coronary is the name of the vessels give the blood to the heart, and then coronary artery disease, it means that we have some blockage in the vessels of the heart, give the circulation and blood to the heart muscle. So if there is some blockage, what's going to happen? People getting the heart attack, right? A stroke. If we have those bad cholesterol or triglyceride, bad fat, accumulate in the vessels of the brain, also people can have ischemic or a special type of the stroke, which is unfortunately one of the most common one. Blockage in the vessels that give the blood to the lower extremities, to the legs, that peripheral artery disease. In general, any type of atherosclerosis, I mentioned about heart attack, the kidney disease. If the blockage in the vessels of the kidney happen, you can have the chronic kidney disease. Same thing in the vessels of the neck and fatty liver. One of the things that I really want to emphasize, especially one of the most common dementia. Because what's happened, the small tiny vessels of the brain getting blocked because of the cholesterol and triglyceride. And what's happened, small every day, just few of those cells that not getting enough oxygen and not enough circulation in the brain cell will die. So eventually as we age, without even having special symptoms, one day waking up with a stroke, a small little dying the cells of the brain cause a special type of dementia. They call it vascular dementia, and is unfortunately one of the most common. Gallstone and pancreatitis is other common complication of the high hyperlipidemia. So, okay, so we discussed about what can cause that. What we need to know about the screening of the disease. So, number one, we need to know that this is a very common and prevalent condition. 1 out of the 3 adult Americans has elevated bad cholesterol. Just remember, here I'm not talking about the bad cholesterol and triglyceride diet. I'm talking about only the LDL by itself. 1 out of the 3 adult American. That's crazy. That's really, really concerning. And I want to bring your attention to another high number about the 1 out of the 4 people die in the cardiovascular disease in the United States of America. So see, those are very closely related, right? And we know that with starting the screening and early detection, we can start the early intervention and technically prevent all those catastrophic complications of hyperlipidemia. So what age we need to start the screening? Number one, I want to tell you, screening is so simple. Blood test. Doing a blood test, simple blood test. And that's another reason we always telling our patient, please, please, please make sure that you see your primary doctor at least once a year for your physical, because that's the time they can screen your blood for different, conditions. One of them is high cholesterol. But if you are thinking, okay, I'm healthy, I have no symptoms, why I need to go and see my doctor? I mean, I have so many more important things to do. Guess what? We will miss that chance of early detection, because like many other chronic disease with all those life-threatening serious complications like heart attack, those are start with no symptoms. High cholesterol, most of the time, has no symptoms until the last minute, people getting a heart attack or stroke, right? High blood pressure, exactly same story. Many times patient has no symptoms whatsoever except going to see a doctor and then do a screening for that, right? Diabetes, even diabetes, many times, many years before starting the symptoms, patient already had the high blood sugar. But if you're not seeing your doctor, you don't know that, okay? So usually it's saying that start at age of 35 in the men, start age of 45 in the women, or if you have no risk factor. But let me tell you one thing. My experience as practicing physician for 20-something years, I'm telling you, every single of us has at least one risk factor. Guess what? Most of us have a sedentary life. Family history, bad diet, all of those things. Put it together, we have one of those at least. So at least we need to start a screening at the age of 20. And even in the young, children, sometimes we need to start the screening at younger age than 20. Okay, so I'm going to just emphasize a little bit about the cardiovascular disease. Is number 1 killer of the women and men globally and in United States. Unfortunately, every 34 seconds, one person will die because of cardiovascular disease, heart attack and stroke. So now I'm talking about 5 minutes, right? So far, 5 minutes is 10 people already dead because of cardiovascular disease. In the last 5 minutes, we are already sitting here and talking about the high cholesterol. So it's really a serious issue, okay? And almost 1 out of the 4 people will die because of cardiovascular disease, as I mentioned. A little bit more emphasis of why is important. Cardiovascular disease by itself. Look at that. Okay, so, sorry. cardiovascular disease by itself can kill more people than all the cancer together. You know how much we afraid of cancer, how much we are just, seeking for a way to detect the cancer. The heart attack, and I'm just looking at that, I don't know which one is pointer, this one? Yeah, okay, so look at that. The first line is the heart attack by itself. A stroke is a little bit down there, I don't see it very well, but is one of those, stroke is here. So the heart attack by itself killing more than all the cancer together. Can you believe it? And then amount of attention we are giving to the cancer, which is good, but we are not paying enough attention to heart attack and stroke, and we can prevent it. Just remember, the most of the risk factor is preventable. So that's one thing we need to pay more attention to it. So just as you can see here, the high cholesterol is one of the most common major risk factor of heart attack and a stroke. So one thing I want very quickly discuss about that. Okay, so let's go here. So probably you cannot hear me. Okay, so you can see here. So the bad cholesterol, I'm talking here about the LDL, bad cholesterol, start depositing between the layers of the vessels. This is the vessels wall, okay? So when we have a small little damage, either because of smoking, because of diabetes, because of the high blood pressure, so a small little tiny damage, that LDL going and start depositing between the layers of the vessels. Vessels are not like a pipe, okay? Has different live layers, have a muscles and different layers, okay? When we have that, this one going start here and then getting stuck there, and then I will show you the next picture. So start, look at that. We have depositing the bad fat or the LDL here, and those cells, which is the immune cells of our body, coming here and trying to clean up the area, okay? So what's happened over the time, of course, that just, the open, wound started, right? So unfortunately, the most of the time, the bad cholesterol is just keep accumulating, and this, that the blood area that blood can go through is getting smaller and smaller, and then it's getting thicker and thicker, and especially, unfortunately, the cells going to eat the bad cholesterol actually make it more swollen, and then the thinner the layer, the thinner, the narrower the vessels wall, the vessels area. So, and then eventually getting kind of blockage with some blood clot, and then guess what? No blood going through, and then the heart start blockage, and heart attack happen. Look at that. There is some blockage here, and then all those areas you can see different color is already dead. And that's the time that heart attack already happened, okay? Guess what? That part is never going to be healed by itself. So we can prevent that. The treatment is the lifestyle and medication. There is different type of the medication. Statins, one of the most common, Zetia or ezetimibe, PCSK9 inhibitor, which is Repeta, and bempedoic acid, which is the newer medication for those people not having the tolerance to statin, and fenofibrate, niacin, and omega-3. But why the doctors, including myself, the first things we want to start is a statin. And then the reason that because the study supporting the benefit of a statin, not only for bringing down the bad cholesterol and the triglyceride and bringing up the good cholesterol is so strong. Also, we have the strongest data in the area of medical research supporting that that's one of the few medication protecting the heart and brain, and also decrease the mortality. Not only heart attack and stroke, actually a study shows decrease the all-cause mortality. That's one thing that's very interesting, and I'm bringing those data here. So just look at that. That study shows they did a study in more than 9,000 patients. That N, it shows the number of the patient that was a volunteer in that study. You can see the people were taking a statin is living longer and dying less than the people that not on a statin. So it's not one patient, one person coming and saying, okay, I like the medication or I do not like the medication. 9,000 people has been studied, and the result of that high volume of number of patients or participants show that. Another study, almost 4,000 people volunteered and get into that study. Look at that. The number of the people not on the statin and dying versus those people that live longer and dying less. It's not one person telling me is good or one doctor telling me is good. And each of those study takes years and years to conclude it. And many scientists put their time and effort to get to one manuscript. I'm telling you because for the last 20-something years, not only I'm practicing, I'm doing independent research. Okay, so another study, that shows that 7,000 people. Look at that. Significant improvement and people dying less when they are on statin. Look at that. Can you see that? Isn't amazing? So, and then we have another, the same study, another, evaluation. So you can see the huge difference on the people that taking a statin versus not taking a statin. And that's the reason statin is one of the strongest supported by research. And those research, by the way, those research are done by independent scientists. So not related to any of those pharmaceutical company. Okay, so because when the study is the pharmaceutical company, as far as the level of accreditation, we consider different, okay? Because there might be a little bit biased, right? So number one, there is some myth and fact about the statin. One of them is the statin can cause severe side effect in everybody. Okay, so that's one of the most important things I want to discuss here. Most people tolerate statins very well with the minimal or no side effect, okay? And that's coming from data. So the scientific data and the study shows that the true statin intolerance happen only in 5 to 10%. And the most of the side effect is from the nocebo effect. What is the nocebo effect? If you want to learn one thing from today's lecture, I want you to learn this. Nocebo effect, just remember, when we used to say, okay, you are taking the pill, if you are taking a sugar pill, still you feel getting better, they call it placebo effect, right? Sugar pill, also some people taking it because of those, thinking that I'm taking something, I'm feeling better, they might feel better. But they did a study that they did show that those people that they are because now just, many people thinking that the statin is not good. They did a study and showed when they put 3 groups, one group with a statin, one group without a statin, and one group with placebo, they showed that those groups that they were taking statin, they had almost similar side effect of the group of placebo, but significant difference on the group that are not taking anything. So the fact that you are taking something, because you are assuming, you are expecting you will get some joint pain, muscle pain, you will get something. So now there is something they call it nocebo effect. So when we are, and then just remember, one of the most common side effects is what? Joint pain, right? Joint pain is the perception, is what we can feel. It's not like a bump, you can see it in your hand, right? So it very easily can be dictated by our brain and our belief or concerns. So, and then the study showed that, right? So the nocebo effect is driving most of the side effect. The other the myth is just a statin damage the liver. Actually, a study shows if some people increase the liver enzyme, if those people show that, is usually very minimal, and the importance of decreasing the heart attack and stroke and mortality is much, a small little increase of the liver enzyme, and one of the reasons that we will monitor liver enzyme. The other myth is just statin can cause diabetes in healthy people. Actually, that's not true. Some people might increase about A1C, but one of the huge study done to just, evaluate is that correct or not, and they showed that sometimes might cause slight increase in A1C, but is the benefit of the reduce of the heart attack and the stroke is much more potent and significant. So the other misinformation is statin causing weaken the muscles, which the study shows exactly the same thing. Only 1% of a statin user might have the actual joint pain and muscle pain, and then we can test by the blood test. When the cholesterol is improved, we can stop the cholesterol medication. Absolutely wrong. If your cholesterol is getting better, not necessarily you can stop that. It's based on the decision that your provider can do that. Some of the people, for example, the people with diabetes, if they're above age of 40, they need to be on a statin regardless of cholesterol. If somebody has already heart attack and stroke, they need to be on a statin. But some group of the people, we might be able to remove them from the statin, but needs to be based on the medical decision from the provider. Sometimes we discontinue it, but it's just case by case, but the patient shouldn't stop that on its own. And those is money-making sham by the pharma. Actually, the statin now is kind of not causing that significant benefit for most of the company. And then let me tell you, just aside, that many of those pharmaceutical company that are making the over-the-counters, which not going over under the FDA regulation and checking by the FDA, they are making much more money than the pharmacy that making a statin. So statin has the reduction of heart attack and also dementia, anemia, anti-inflammatory property, and possible reduction in dementia risk, as I mentioned. I'm trying to finish it very fast. It's important to address your concern, discuss it with your doctor. It's so important to bring your concern, because a doctor that has enough education on clinical lipidology should be able to address the most of your question and concern. Each person has a different risk assessment and scores, and then lifestyle change is the cornerstone of treatment before starting the statin, and also we need to continue when you are on a statin. So I'm going to just pass some of those, which here is just the study shows that just having is the nocebo effect. Taking something, it does show that you might develop some of those risk, the side effects. And okay, so that's one thing is important. If somebody has the high good cholesterol, is good. Actually, that's another myth which is not correct. The good cholesterol, just the normal amount is good. If we have the higher amount, actually increase the risk of cardiovascular disease, and studies showed that. So don't imagine that, okay, I have a lots of good cholesterol, I'm safe no matter how much is my bad cholesterol. The treatment goal is the triglyceride and LDL. So It's important to bring the LDL less than 40. For the very first time, we show that the people with the lower LDL, they can regress that plaque. Do you remember those plaque that blockage the vessels circulation? If the LDL bring less than 40, now for very first time, we see that the plaque can shrink. Still, we need to do more study, and I know that some very strong studies working on that. And as you know, that statin comes from all those medically driven guidelines. So, American Heart Association, American College of Cardiology, NHL, USPS Task Force, Academy of Pediatrics. I mean, you can see all those, and each of them has thousands and thousands of the doctors and scientists, and get to that conclusion. So to bring down the cholesterol is one of the most important things we need to do. Unfortunately, we have some barrier here. Sometimes is the inertia from the physicians, unfortunately, because not necessarily all the physician has the clinical lipidology training. Unfortunately, only 700 people in United States has been able to get board certified in clinical lipidology. But then the most of the doctor knows the importance of controlling the cholesterol, but starting the statin, still there is some inertia, and then unfortunately the patients misinformation from the family and friends, which are not a doctor or Dr. Google or Dr. ChatGPT now, which they never been to the medical school. They are just giving the wrong information to the patient. Take home message, make sure that you are technically knows the importance of that. It can cause the heart attack and a stroke. And then we need to make sure early detection is important because we can start a prevention and treatment matter. Please make sure you get the information from medical doctors, not everybody in the YouTube and TikTok saying that I'm a doctor, not necessarily just delivering the correct information. And trust the science, not misinformation. And the reason I'm putting that, I'm almost done, okay. So remember, when the James Webb came and all those amazing, magnificent pictures of the universe, which was mind-blowing, so guess what? All those happened, and then, but based on those scientists making that. If I'm telling you as a person that used to be in love with the physics and all of those things, the complexity of each of cells function and physiology and all of those things in every single cells of your body, you're sitting here, is not less than the complexity of universe and galaxies. I'm telling you because I have kind of a little bit of information about both, okay? So for learning about James Webb, making James Webb, learning about the universe, you're not going to listen to the family or friends or somebody who is not specialized in that, right? You are going to learn from somebody who spent the life to learn about that, who is a really scientist, and not even each person saying that I'm scientist, right? Somebody that teach the university those things. For making those James Webb things, you're not asking somebody does not know the stuff making that. Somebody knows the stuff making that, otherwise it won't work. So why about one of the most valuable things we have, which is our health and our body, which is as complex as a universe, we are going to listen to somebody who has no knowledge or training about that. That's the reason I put that picture. Please take your life and health seriously. Do not put your life or your loved one's life in danger with listening to the misinformation. Thank you. Wish you all healthy life and good cholesterol high, low, bad cholesterol low. Thank you, and sorry for the long presentation.
Thank you, Dr. Rezaeian. Our next speaker is Justin Cavalari. I believe I have this right, Doctor of Pharmacy. And Justin is a pharmacist at Torrance Memorial Medical Center who recently received his interesting degree, PharmD, P-H-A-R-M-D, in 2024 at Chapman University. He first started his journey at Torrance Memorial in the radiology department before transferring over to the pharmacy department, working as a pharmacy technician until finishing pharmacy school. His favorite part about being in the medical field is not only taking care of sick patients, but also participating in events for the community, such as this one. So, Dr. Cavalari, come on up.
Thank you very much. Good evening, everyone. Thank you for coming here tonight. It's a pleasure being here, to be in front of you. And for you all being here, it says a lot about your commitment into a healthier life. And when it comes to treating high cholesterol with medicine, statins on top of that with ezetimibe are a staple. But a question that does come up is, what are our options when statins and ezetimibe aren't enough and our LDL, our bad cholesterol, is still above goal? This is where PCSK9 inhibitors come into play. And with PCSK9 inhibitors, I know some of us may not be too familiar with that, but I will shortly get into that very briefly. The three main ones that are FDA approved currently are Praluent, Repatha, that we have up here on the screen, and Leqvio, which is one of the newer ones. So what makes this type of medication, PCSK9 inhibitors, so special? Especially when it comes to managing high cholesterol. Right here is a table where it shows where PCSK9 stand up with statins and ezetimibe and how well they can lower our LDL. As you can see here with PCSK9 inhibitors, our max reduction in LDL is maxed out at 70%, which is pretty considerably higher than ezetimibe and also higher than statins, our max dose of statins at that. PCSK9 was an important discovery in the early 2000s, and it led to the first FDA approval of a medication targeting PCSK9 in 2015. But before we get into this, into all the medications we have available, let's talk about what PCSK9 is. It was discovered in 2003, like I said. It stands for, I know this is a mouthful, but it's proprotein convertase substilicin kexin type 9. It's a chaperone protein that comes from the liver, and it facilitates LDL receptor degradation. So if I may, I'd like to introduce kind of like a visualization for you all. I'm not sure how many of you all are football fans here, but let's think about LDL receptors in our liver that are attached to our liver cells. They're like wide receivers, and the wide receivers are kind of, their job is to catch footballs. And let's imagine the football being LDL cholesterol. And so when the receiver, our LDL receptor, catches the football, or LDL in this case, what typically happens to a receiver? They'll probably get tackled, right, by the big linebacker, the big hard-hitting safety. And that tackler is PCSK9. And so what happens is that PCSK9 will attach onto the LDL receptor and tackle it into the liver enzyme where the LDL receptor as well as the LDL will then become degraded inside. But what PCSK9 inhibitors can do, what protects wide receivers from getting tackled from a big tackler? Offensive lineman or a blocker. And so PCSK9 inhibitors can be considered a blocker, and they'll block these LDL receptors from being attached to PCSK9. In this case, the LDL receptor will be able to attach onto the LDL, bring it in, still have the LDL degraded inside, but can come back out and attach onto multiple LDL molecules. So it can be recycled and reused. And so there are two ways. So that was the first way, which is what alirocumab, which is the brand name Praluent, and evolocumab, brand name Repatha, does for us. The second way is by using a small interfering RNA molecule that's aimed at PCSK9 mRNA. And an example of this is the newer one, inclisiran, brand name Leqvio. Now that we have established what PCSK9 is and what PCSK9 inhibitors do for us, where is their place in managing our cholesterol levels, our LDL levels? According to the 2018 American Heart Association and American College of Cardiology guidelines, PCSK9 inhibitors can be considered for two groups of patients. The first group are those who are considered very high risk ASCVD patients who have their LDL levels greater than 70, but they're already on a max dose of ezetimibe and statins. And being very high risk ASCVD means either being a patient that has had 2 or more ASCVD events, like a heart attack, hospitalization due to unstable angina, ischemic stroke, or having symptomatic peripheral artery disease. Or they can have one of those mentioned events plus 2 or more high risk factors that are listed here on the screen, such as being 65 years and older, having diabetes, hypertension, or having chronic kidney disease. And it's important to note that the AHA and ACC, they do mention that the long-term safety of these types of medications is unclear. So specifically speaking, beyond 3 years, but within the 3 years, there's definitely been a good amount of LDL reduction seen here. Now, the first PCSK9 inhibitor I'd like to go over is Praluent. FDA approved in 2015 for patients as young as 8 years old. And dosing comes in a couple of options. The first option being 75 milligrams or 150 milligrams subcutaneously injected every 2 weeks. And the other one being 300 milligrams subcutaneously injected every month. And these are self-administered. So patients are allowed to take these medications home and keep them in their refrigerator where they are to be properly stored. This medication first got its real good reputation with the landmark trial called the Odyssey Outcomes, which was in 2018, where approximately 19,000 patients who had an ACS event, like a heart attack or unstable angina, who were already on statin therapy but still had LDL levels greater than 70, they experienced an average reduction of LDL to 48, which is a substantial amount, after 1 year of treatment. And then after a median follow-up of about 2.8 years, there was an observed 15% relative risk reduction of primary endpoints such as a heart attack, ischemic stroke, and coronary death. And in terms of the side effects with Praluent, the most common one that was observed by patients were mild injection site reactions that include swelling, redness, and itchiness. So it's safe to say it's been pretty tolerated well by patients. Now, the second PCSK9 inhibitor I'd like to go over is Repatha. This was also FDA approved in 2015, same year as Praluent. And it was FDA approved for patients as young as 10 years old. Dosing has a similar schedule to Praluent, wherein it's 140 milligrams subcutaneously injected every 2 weeks, or 420 milligrams subcutaneously injected every month. And this is also self-administered. The landmark trial that gave Repatha its reputation was the Fourier trial, which happened in 2017, where approximately 28,000 patients with a history of a heart attack, stroke, peripheral artery disease, who are already on statins but still had LDL levels greater than 70 as well. What was discovered that after 1 year of treatment, the average LDL level was at 30 milligrams per deciliter, which was also pretty significant here. And after a median follow-up period of 2.2 years, there was also about a 15% relative reduction rate in occurrences of heart attack, cardiovascular death, non-hemorrhagic stroke, and hospitalization for unstable angina. And just like Praluent, most common side effect were the mild injection site reactions. Now, lastly, is the small interfering RNA medication, the inclisiran, also known as Leqvio, which was FDA approved in 2021. The dosing is a little bit different. It's a little less frequent. So for those patients that really don't like injections so much, this could be an option. It's 284 milligrams subcutaneous on day 1, then at day 90, so 3 months after. And then after that, it'll be every 6 months. But this medication is provider administered. So a patient would have to go to their doctor's office to receive, their dose and their medication, which can be a good thing just to ensure that the timing of the doses are on time and appropriate. And so the landmark trials actually that gave Leqvio its reputation were the Orion series trials, specifically Orion 10 and Orion 11. So in the Orion 10 and Orion 11 were roughly around 3,000 patients with LDL levels greater than or equal to 70 who were already on lipid-lowering medications such as statins for at least 30 days. After about 1.5 years of treatment, they, on average, reduced their LDL levels by approximately 50%. And the side effects that were most commonly reported were, again, mild injection site reactions. However, with Leqvio, there is some concern for pregnant patients. There is a potential risk that's just potential risk to the fetus based on the mechanism of action of Leqvio, but there's not enough data right now to say for sure and to say concretely that it is a major risk right now. When treatment with PCSK9 inhibitors is initiated, we generally would like to perform a lipid panel 1 to 3 months after initiation. And as I've mentioned earlier, the injection site reactions are a common side effect, but in addition to that, there's also possibly some signs of myalgias, but it is rare, and GI upset. And with Praluent and Repatha, we would like to store those in the refrigerator, but they can be kept at room temperature for about 30 days. And prior to administration of a dose for those two medications, we would like to leave them out and let them warm up to about room temperature for about 30 minutes before administering. With Leqvio, that is typically kept at room temp, not in the refrigerator, in contrast. But for all three, in terms of administration, especially if we're self-administering Praluent and Repatha, we like to do it subcutaneously, like I mentioned. And this would be at 45-degree angles. And this is either on the top of the arms, top of our thighs, or on our belly. And this would be, if it's on the belly, it has to be 2 inches away from our belly button. And to prevent those injection site reactions, it's recommended to rotate your injection sites just so you don't get too much irritation in one spot. Now going on to the cost, and I know this can be a big issue for a lot of patients. So back in 2015, when Repatha and Praluent were first FDA approved, the annual cost of PCSK9 inhibitors was approximately $15,000. But today, it has dropped down considerably, but it is still a significant amount. For Repatha and Praluent, the annual cost is now $6,500. And then for Leqvio, although it is less frequent, the approximate dose price is $3,600. And so to get this covered, I know this is a lot, but prior authorization is typically required from insurances to get it covered. And with recent data, Medicaid and commercial payers have shown to have lower approval rates compared to Medicare. But not to worry, to increase the higher probability of gaining coverage, recent data also shows that if a patient is 65 years and older, they have a higher chance of getting approval, as well as if they have a history of an ASCVD, as well as having the medication prescribed by a cardiologist. Now, with that being said, I know those numbers were big, there are other options as well that the manufacturers such as Amgen do offer. I'm not too sure if everyone's familiar with like these copay cards that you can find on manufacturers' websites. They also have care programs. But I know it's a lot of information, but it is something that can help if we do need to use these PCSK9 inhibitors for the betterment of your health. They also offer representatives that you can call that can walk you through step by step, because it is a lot of information to digest when going through whether you are eligible, depending on your insurance, depending on your income. But they're there just in case. Now to sum up what PCSK9 inhibitors are in cholesterol management, initiation of this type of medication can be considered, again, for two groups: very high-risk ASCVD patients who are already on maximally tolerated statins and ezetimibe, but still have LDL levels greater than 70. And the second group would be those who have severely high levels of LDL, typically characterized as over 190, and who are already on maximally tolerated statins and ezetimibe. There's still not enough concrete data to ensure the long-term safety of using PCSK9 inhibitors beyond 3 years, but as I mentioned, within those 3 years, there is definitely a good benefit to be had when using these medications. The most common side effects were injection site reactions, muscle pain, and GI issues. And Repatha and Praluent dosing is either every 2 weeks or every month, while Leqvio is day 1, day 90, and then every 6 months thereafter. All three medications are relatively expensive, but there are options to help alleviate that, whether it's through the prior authorization process or through the manufacturer's care programs or copay card programs. Lastly, I'd like to reinforce the idea that medicine, such as the one we've discussed so far, to treat high cholesterol or high LDL levels, is generally our secondary option, and it is there to help assist us in getting to our health goal. And I understand that statins and PCSK9 inhibitors have the potential to lower our LDL levels by more than 50%, but I do want to reinforce that diet and exercise will always be the most effective way in combating high LDL levels. And it is our primary method of keeping our cholesterol levels healthy. So I really appreciate your time and thank you for having us. And I hope you learned something. Thank you.
Well, it was certainly informative to me as someone who's been on a statin for years. I didn't know there were any other further options, but thank you. And pardon me. Your last statement about diet and exercise leads right into our third speaker, Erica Drost. She's a registered dietitian nutritionalist dedicated to helping people foster sustainable eating habits that promote long-term health and well-being. She holds an undergrad degree in public health from Taylor University and a master's in nutrition from the University of Illinois at Chicago. With this background, she's learned the importance of creating environments in which people can be healthy, at the same time empowering people to take control of their health. At every stage of life, that long sentence, I didn't read it right. Passionate about debunking nutrition myths, Erica aims to be a trusted partner to her clients' health journeys of healing their relationship with food. Didn't know I had a relationship. I guess I do. Yeah. She currently teaches the Cancer and Nutrition series, Nutrition During Cancer Treatment, and the Live Well After Cancer Therapy classes. So welcome, Erica Drost. Sorry if I stumbled over some of that.
As usual, saving the dietitian for last. Maybe it's because if we talk about food too early, you guys will get hungry and leave. But hopefully you can stay with me. Amazing. Well, excited to be diving into this topic tonight, all things diet and heart health, the best ways that we know to improve our blood lipid levels. So just as an overview, we will dive into the different types of fats found in food, why that's important, and then address some common questions that I hear about fats, and then hopefully give you some practical takeaways. All right, getting right into fats found in food, we can divide them into three categories. So we have saturated fat, we have unsaturated fat, which can further be broken up into monounsaturated and polyunsaturated fats, and trans fats. So because of their chemical structure, saturated fats are solid at room temperature. And as was so beautifully explained before, unsaturated fats are, or diets that are higher in saturated fat are linked to increased LDL cholesterol, and increased risk for stroke and heart disease. Unsaturated fats, on the other hand, are liquid at room temperature, and they have been shown to help lower the LDL cholesterol and may maintain or raise good LDL cholesterol or HDL cholesterol. Diets higher in unsaturated fat have a reduced risk for heart disease and stroke. Trans fats are mostly man-made fats and occur as partially hydrogenated oil, or PHOs. So these PHOs are basically made by adding hydrogen to vegetable oils, which vegetable oils are naturally liquid at room temperature. But when you add hydrogen, it makes them kind of semi-solid at room temperature and it extends their shelf life. So talking about the good, the bad, and the ugly with fats, these are the ugly fats, right? They raise bad cholesterol and lower good cholesterol, so increasing your risk for heart disease and stroke. The FDA actually banned trans fats from the food supply in 2019. So for the most part, it's not a huge issue anymore. But the caveat there is that not all trans fats, not all countries have banned trans fats, so some imported items could still have them. And if the package says 0 grams trans fat, legally that product is still able to have 0.5 grams per serving. So you just have to look at the ingredients list to see if there are any PHOs listed. So really simple bottom line, we're wanting to really avoid those trans fats. We're wanting to moderate our intake of saturated fat and enjoy unsaturated fats. So what does that translate to in food? So food sources of saturated fats, the vast majority of saturated fats in our diets does come from animal foods, mostly red and processed meats and full-fat dairy. So red meats being any beef, pork, or lamb. Processed meats, so things like sausage, bacon, hot dogs, deli meats. And then even leaner meats like chicken and turkey, eating them with the skin on them, right? That will be higher in saturated fat than eating without the skin. And then the part of the bird, right? So the breast will be leaner, aka less saturated fat than like the thigh or the leg. And then full fat dairy, so butters, creams, whole milks, that kind of thing. There are some plant-based sources of saturated fats, mostly from coconut and palm oil. But to complicate things a little bit more, not all saturated fats are created equal. I won't spend too much time on this slide, but just to say there are different types of saturated fats. Some may be more beneficial or neutral than others. The ones that seem to be the most harmful to cholesterol and heart health are those long-chain saturated fats, especially from palmitic acid, from like meat, dairy, and palm oil. So there's not so much of a concern from those short-chain acids or medium-chain saturated fats from things like coconuts or fermented dairy. But at the end of the day, these are all saturated fats, so we still want to think about it through the lens of that yellow traffic light, including them in our diet in moderation. Okay, moving on to unsaturated fats. So these are the heart-healthy fats that we want to choose the most often. Unsaturated fats can be further broken down into two categories. So we have monounsaturated and polyunsaturated fats, or MUFAs and PUFAs, because it's more fun to say. So MUFAs, monounsaturated fatty acids, you can find in things like all oils, so olive oil, canola oil, nuts, things like almonds, cashews, peanuts, pecans, different kinds of seeds, of course, nut butter, so almond butter, peanut butter, and olives. And then PUFAs, there are two main kinds of polyunsaturated fats. We have omega-3 and omega-6. You can get omega-3 fatty acids from fatty fish, particularly things like salmon, mackerel, anchovies, sardines, and herring. And then also some plant-based sources as well, like flax seeds and chia seeds, hemp seeds, and walnuts. Omega-6 fatty acids you find in certain kinds of oils, for example, sunflower, safflower, corn and soybean and sesame, and pumpkin seeds and pine nuts as well. Food sources for trans fat. So there is a very small amount of natural trans fat in some foods like meat and dairy products, but the biggest culprit, like we mentioned earlier, are those PHOs, the partially hydrogenated oils. So these are found in ultra-processed foods, right, and deep-fried foods. Definitely not an exhaustive list here, but just some food examples. Great. Okay, so we've looked at the types of fats in food and the foods that contain them, but how much fat do we actually need? So the dietary guidelines for Americans recommend to have about 20 to 35% of our daily calories coming from fats. Now, this is very generalized, right? So everyone's needs will be individualized. But based on a 2,000 calorie diet, that comes out to about 45 to 78 grams of fat per day. Now we want most of that to be coming from unsaturated fat sources, right? So only about 22 grams of that should be coming from saturated fat, or about 10% of our total calories. If you are at higher risk for developing heart disease, right, you have a strong family history, Recommendations are to limit saturated fat even more to only about 5 to 6% of total calories, which comes out to about 11 to 13 grams of saturated fat per day. And really just to emphasize, it's not about doing no fat or low fat diets, right? That's not really supported by the research. It's about choosing the right quality of fats. Because there are essential fatty acids, right? Meaning our body is not capable of making on its own. We need to get them from our diet. So those two essential fatty acids are omega-3 and omega-6. Specifically alpha linolenic acid and linoleic acid. So it's not too important that we get hung up on this ratio. We do ideally want more of a 4-to-1 ratio between omega-6 to omega-3. So the typical American diet is more of like a 15-to-1 ratio of omega-6 to omega-3, which may contribute to some kind of inflammation. But, and this is a big but, I do get a lot of questions about omega-6, like rich oils, and people concerned about those oils causing inflammation. People are worried, can I have oil? What oil should I choose? So this is just a breakdown of different types of oils and the fats that are in them, right? So as you can see, all of them have a mixture of different types of fats, but in different proportions. So the very quick bottom line answer to this question, oils are not inflammatory when eaten in moderation, right? There's no data to support that omega-6 rich oils increase inflammatory markers. Most omega-6 rich oils do come from processed foods though. And then 65% of the American diet is ultra processed foods. So if you're worried about inflammation, I would decrease the amount of processed food in your diet. I wouldn't be so worried about cooking with a little oil at home. And then always when we're talking about nutrition research, and we ask the question, is it quote unquote good? Is it quote unquote bad? We always have to ask compared to what, right? So it's never black or white. So of course, when we replace butter with oil, that's going to be beneficial. We see that in the research. When we replace saturated fat with unsaturated fat, we see benefits in heart health. But if we take that a step further, right, and we use whole food fat sources like avocados, nuts, seeds, olives, those are going to be even better than oil, right? So always have to keep that hierarchy in mind. So it's not necessarily helpful to categorize foods as quote unquote good or bad. We just always have to ask compared to what. But really using oil at home is definitely part of a heart healthy diet, especially if it's those unsaturated fat oils. Okay, more questions I get. I'm gonna need your help. If you haven't already cheated yet, I know you have all the answers in front of you. But what about cholesterol in foods, okay? By a show of hands, raise your hand if you think this statement is true. If my cholesterol is high, I need to avoid things like eggs and shrimp. Okay, got some hands raised. So it's not necessarily true, right? A lot of people will say, I need to eliminate eggs and shrimp from my diet because they are high in cholesterol. But actually, there is no recommended daily limit for cholesterol. The dietary guidelines for Americans used to have a limit of 300 milligrams per day, but they've since removed that because there was a lack of evidence linking cholesterol-rich foods with elevated blood cholesterol. So dietary cholesterol, so the cholesterol in foods, has much less of an impact on blood cholesterol than we previously thought, because we now know that the saturated fat in the diet has a much bigger influence on our blood cholesterol. Now that doesn't give us free rein to eat all the eggs and shrimp that we want, but we don't have to be necessarily scared of them or feel like we have to completely eliminate them from our diet. What else can I do to lower my cholesterol? Show of hands if you think this is true. Avoiding foods high in, adding foods, high in fiber can help lower cholesterol. Got a lot of hands. This is absolutely true. Yes, we know from research that diets that are higher in fiber typically have lower cholesterol. So fiber is only found in whole plant foods, right? Fruits, vegetables, whole grains, nuts and seeds, beans, lentils. And we should be aiming to get about 25 to 38 grams of fiber per day. What about high triglycerides? We spend a lot of time talking about cholesterol, but what if you have high triglycerides? True or false? Show of hands. Eating a diet high in added sugar and refined carbohydrates can contribute to high triglyceride levels. We alluded to this a little bit earlier. Yes, this is true. So definitely be mindful about choosing healthy fats is going to be helpful for triglycerides too, not just cholesterol, but in addition to that, choosing quality carbohydrates turns out to be really important as well. So if you are at higher risk for developing heart disease, the American Heart Association recommends limiting added sugar to about 5% of total calories, which comes out to about 25 to 36 grams of added sugar per day. And then trying to choose those whole grains versus refined grains, right? So whole grains being things like oats, brown rice, whole grain bread, whole wheat pasta, quinoa. And then refined grains being those snack foods, those processed snack foods, baked goods, white breads, that kind of thing. It's also recommended to limit alcohol consumption because that can contribute to high triglycerides as well. Okay, can I increase my good cholesterol, my HDL cholesterol? Much harder to do, but you can. Actually, one of the best ways to increase HDL cholesterol is not through diet, but physical activity. So aerobic physical activity, anything that gets your heart pumping, brisk walking, running, cycling, swimming. Threw a trick question at you at the end. All right, just to reiterate, diet is just one piece of the puzzle, right? Many different things affect our blood lipid levels. Sleep, stress, physical activity, smoking, those are all really, really important modifiable risk factors as well. And then genetics, of course. All right, great. We're just gonna summarize the top 3 things diet-wise to help with our blood lipid levels. First, prioritize healthy fats, right? So choosing unsaturated over saturated fats. And then tips, this could look like, replacing butter with oil, olive oil, canola oil, avocado oil, for example. Swapping beef, pork, lamb for leaner proteins like chicken or fish. Eating 2 servings of fish per week. Ideally those fish that are higher in omega-3s, like the salmon, mackerel, anchovies, sardines, and herring. Maybe choosing a handful of nuts or seeds for your snack. The second one, so boosting your fiber intake. So tips in this category include choosing more vegetarian sources of protein, right? So beans, lentils, soy products, having fruits and vegetables with every meal, and then swapping those refined grains for whole grains. Maybe adding things like chia seeds, hemp seeds, flax seeds to your meals. You can add them to oatmeal, to smoothies, to salads, baked goods. Really good way to get in a little bit more fiber. And then lastly, cutting back on added sugar and refined grains. So maybe some tips here could be using some mashed bananas, right? Or applesauce or dates as sweetness in a recipe. Swapping some juice or soda for like a flavored sparkling water. And then swapping those processed snack foods, anything that you find in a package or a box for things like hummus and veggies or nut butter and fruit or guacamole and whole grain crackers. Maybe replacing the sugary breakfast cereal for more of a homemade oats with some fruit for sweetness. Thank you so much. That's all that I have for you tonight. Thank you for having me. And of course, happy to answer any questions in the Q&A, but wanted to highlight if you have specific individualized questions and want to speak to a dietitian one-on-one, please check out our outpatient nutrition services. You can call this number to schedule an appointment, and we would be happy to follow up with you. Thank you so much.
Thank you, Erica. Okay, at this moment, we're going to take a short break. And members of the Miracle Living Committee who are bounding up over here on the right, if you'd like writing instruments and paper for questions, flag them down. They will hand those out to you and collect them and bring them up here, and then we will process the questions to our panel and get your answers just as soon as the break is over. Okay, we're going to begin with our panel. Any other questions that come in? That's it, okay. We have 4 questions. First one is, would you recommend taking statins even though you have low cholesterol?
I think that's the question for me. So
Is anything working?
can you hear me? Okay. Sorry for that. So it really depends on the case. Most of the time, if patient does, can you hear me? Okay. So if you do not have any other conditions, no, you do not need to take the cholesterol medication or a statin. If your LDL is less than 100, and now they are just changing the guideline, they are talking about 70, which is going to be a new 100. But yes, if you do not have any other condition, the ASCVD or the cardiovascular risk factor are low, risk assessment score is low, no, you don't. But there is some conditions that, on that conditions, because you already has a higher risk of cardiovascular disease, then you need to be on a statin, even if, I'm telling my patient, even if your LDL is 0, still you need to be on it, not because the statin is for bringing down your cholesterol. For those cases, for decreasing the mortality of, or just happening of the next heart attack or stroke. One of those conditions is diabetes. If anybody has a diabetes, either diabetes 1 or diabetes 2, and age of 40 and above, regardless of LDL, patient needs to be on a statin, number 1. Number 2 is anybody already had cardiovascular disease, either start some plaques, we do some screening tests or carotid ultrasound or coronary calcium score, and then shows that patient already start building up the plaque. Then is another time that regardless of LDL, patient needs to be on a statin, because we have strong data showing that being on a statin will decrease this risk of the heart attack and stroke on those group of people. So technically depends on the ASCVD or cardiovascular disease risk category, and that calculation and assessment needs to be done by the providers or the physicians. Did I answer the question? Okay.
Okay, is there any data on the use of PCSK9 for post-bypass patients?
In terms of the data for patients post-bypass using PCSK9, I would have to look specifically into that for you. I'd like to definitely get back to you regarding that, but we do know that PCSK9 are very strong in what they do in terms of reducing LDL levels, and especially if they are used in conjunction with statins and ezetimibe, they can definitely decrease LDL levels as well as decrease our risk for cardiovascular issues such as heart attacks or risk of stroke or any other condition like that.
So I want to add something here. So if we are not reaching the goal of LDL for the people that they already had the coronary artery disease, which ended up with the bypass, right? So there is a goal number for LDL, which now they're actually decreasing, and now they're talking about less than 40 based on the European cardiology guideline, which I'm sure that next year they will change the American College of Cardiology and American Heart Association guideline as well. So yes, if you are not reaching the LDL goal with the maximum tolerated dose of a statin, then we need to put the patient on PCSK9 inhibitor. And actually there is a very, very nice study done showing that it can decrease the next, heart attack or stroke and the complication. So the answer is yes, if the LDL goal not been reached by statin.
I think this one must be for Erica. Compare Smart Balance to butter.
Yeah, so butter is going to have a little bit more saturated fats, but still, again, that hierarchy, right? Trying to do more unsaturated fats from oils, like that are more liquid at room temperature, but ideally more of those whole food sources like avocados or nuts or seeds. But yes, maybe butters or Smart Balance would be a little bit better than butter.
Well, here's a related question. I used to use a spread called Canola Harvest. Can't find it anymore. What would you suggest as an alternative?
Yeah, they do have those spreads that are more plant-based oils. So I don't remember the brands off the top of my head, but they do have them. I've seen them in Ralph's or Vaughn's. You can buy like a olive oil type spread butter or ones that have a little bit less saturated fat. So you'll just have to look at the nutrition facts label and kind of compare between the spreads because there are so many out there. But see which ones have less grams of saturated fats and kind of compare that in the store.
Okay, and last question.
One thing, I don't know if I'm wrong, please correct me, but I remember one of those things that they recommended, it was the Benicar, which was kind of the veggies spread. So, and then it was actually recommended in the website of American Heart Association. And, they're really trying to avoid just, advertising any specific brand, but that was one of those that had a very strong data supporting that. So, but unfortunately, my patient coming and saying that is very difficult to find it now. So.
Okay, the last question is, can cholesterol ever be eliminated from the body, and would we want to?
Well, what we know with cholesterol is that it's a natural product that we have that our body keeps producing, and it's important for functions in our bodies such as making up our cell membranes as well as composing the steroids and hormones that we have in our bodies that help regulate our basic function. So we don't necessarily want to get rid of all cholesterol, but as we were saying earlier, is just we want our LDL, which is technically our bad cholesterol, to be at a low healthy level.
I'm glad that you bring up that question because for a very long time, especially when the statin started to be in the market, was one of those, dilemma that are saying that you are giving the the statin to the patient, and then the cells, the body's cells, the cells walls needs the cholesterol. Yes, the statin bring down the bad cholesterol, and that bad cholesterol doesn't do anything with the cell walls or what we need for our body. The bad cholesterol, as name, is bad. So it does decrease the bad cholesterol, which doesn't do anything with the neurocells on the cell walls and nothing, okay? So take your statin without that much of the concern.
Well, that is all of the questions, folks. How about a big hand for our great panel tonight?
I think we might have one more question.
Oh, there's a question.
Okay, well, the question is, having to do with psyllium husk. Is this a good source of your needed fiber? Can you use that?
Yeah, so like a Metamucil.
Could you repeat the question, because any audience is listening?
Sure. The question was about psyllium husk fiber as like a supplement in your drink. Yeah, that would be a good addition. A prebiotic fiber like a Metamucil or a Benefiber would be just another way to get some more fiber into your diet. So I would say not instead of fruits and vegetables, but in addition. Mm-hmm.
One other question. What was the recommended ratio of omega-6 to omega-3?
4-to-1 is the ideal ratio. The standard American diet is typically 15-to-1.
Okay, thank you all for coming this evening. If you've got any further
Sorry,
questions.
one more question.
Well, if you have a further question, I suggest you come up and talk to them individually. Thank you. Yeah, we should always collect the questions, and I'm sorry yours wasn't collected.
Thank you all.
Thank you.
Thank you.